Dear colleagues, I would like to welcome you all to the third day morning of the National Congress of Nephrology. I'm from Ankara Hacettepe University. I am Mustafa Arici. My dear colleague is Dr. Mehmet Koç from Istanbul Marmara University. And we are going to moderate this international session. KDIGO, as you all know, is an organization which is publishing global guidelines for kidneys, which are used by the whole world, and it's one of the most important organizations of the nephrology. With the permit of the KDIGO, we are very happy to organize this webinar because this is going to be an international session. Ankara, Istanbul, Sydney, Delhi, and Newcastle are the locations of our colleagues right now. In this session, we are going to talk about the new guidelines of KDIGO and the future guidelines that will be published. I'm not going to read the CVs of the very important and esteemed speakers. You can find their CVs on the system online. They are all, each of them is very valuable in their field. So we are going to listen to the three speeches one after another, and we will have the Q&A at the very end of all three speeches. Now, if you allow me, I would like to leave the floor to Dr. Germaine Wong from Sydney, Australia. In 2020, she's going to talk about 2020 transplant candidate guidelines. The floor is yours, Ms. Wong.
Thank you so much for the opportunity today to present to you on the Kidney Transplant Candidate Guidelines by KDIGO, published in the Transplantation Journal just very recently. I have no disclosures. This is an outline of my talk today. First of all, I would like to talk briefly about equitable access to transplantation, the purpose of the KDIGO guidelines, with specific focus on three topics of age, comorbidities, and adherence. So we all know that transplantation saves lives even for patients with comorbidities. This is some simulation work that we did quite a few years back, assessing the projected and expected life years and quality of life, adjusted life years in patients with comorbidities who had received a kidney transplant compared to being on dialysis. And as you can see here, even for older patients with cardiovascular disease, the expected survival and quality of life benefits remain superior than being on dialysis. And obviously, the greatest gain is for younger patients with no comorbidities. Also, we all know that transplantation is cost savings, even for patients with comorbidities. And you can see here in the cost effectiveness plane, compared to patients on dialysis, the average savings per patient's life years is approximately 100,000 to 400,000 Australian dollars, depending on the comorbid states. So the benefits are huge. However, not all patients would enjoy the benefits of transplantation, and you can clearly see the disparities in access to transplantation are dominated by age and ethnicity here. This is data from our own Australian and New Zealand Dialysis and Transplantation Registry. The transplantation age over the 60 is 5 times less than patients in the transplantation rate for younger patients in the 20s. Indigenous Australian are also much less likely to receive a transplant than non-Indigenous Australian. And a lot of these are driven by disparity in accessing the actual deceased donor kidney waiting list. And namely, the key factors include the age of the candidates, the ethnicity status, the comorbidity status, sometimes the geography. This is work done by my PhD student recently, indicating that even for obesity, women who are obese are less likely to access the transplant list than men who are obese. So huge disparities are seen here. In 2015, KDIGO, in partnership with the Transplantation Society, brought together a working group co-chaired by Professor Steve Chadban and Greg Knoll, to devise a set of guidelines to ensure a global and unified approach to transplant assessment so that all patients with kidney failure who would benefit from transplantation actually have the opportunity and access to transplantation. In this set of guidelines, the group wants to provide the most appropriate recommendations based upon sound scientific base. The reasons that we develop these guidelines are primarily to assist patients and clinicians about the most appropriate healthcare intervention with the goal of improving quality, access, and process of care. During the KDIGO guidelines development process, we summarized the current medical knowledge using the most up-to-date data. We then appraise and provide the relevant information about the scientific evidence supporting these recommendations. The guidelines recommendations, as you can see here, are informed by both the quality and the strength of the evidence. We use level 1 grade as we recommend when most patients would want the recommended course of action, and when most clinicians feel that the patient should recommend a course of action and that the recommendation should be evaluated for policy development. We use a level 2 grading, that is the term we suggest, when the majority of the patient would want the recommendation and many would not. Most clinicians may have different choices for the patients, and the recommendations are likely to generate debate. We also use the term non-graded to provide guidance that is based on common sense or when a topic does not allow adequate application of the evidence. And this is how we assess the strength of the evidence. Grade A evidence indicates that we're absolutely sure the true effect lies close to the estimates of the effect. And most of these evidence would have come from really high quality trials or systematic reviews. Grade B indicates the true effect is likely to be close to the estimate, but there is a possibility that it may be different. Grade C means that the true effect may be substantially different from the estimates of effect. And grade D indicates the quality of the evidence is extremely low and most likely come from things like case series or case reports or even expert opinions, and that the estimates of the effect are very uncertain and maybe quite far away from the truth. And the scope of these guidelines is huge, and I'm not going to go through every single topic that was covered in a guideline, but I'd like to point to specifically 5 key factors and topics. So age, adherence, diabetes, cardiovascular disease, and cancer are the key topics that I will discuss today. So why age criteria? Well, over the last decade, as you can see here, there is an increase in transplantation rate of older participants in Europe, as well as in the States. And you can see that patients, unfortunately, after transplantation who are older have a much lower survival than younger patients. And in this French study, the estimated 5 years patient survival is approximately 68%, with a graft survival of only 75%. The risk factors for death include arrhythmia, poor left ventricular ejection fraction, the presence of donor-specific antibodies at the time of transplantation, patients that have received a donor with cardiovascular disease, and a history of acute rejection. And the causes are largely driven by infection and cancer. These data are from the Australian and New Zealand Dialysis Registry, indicating the risk factors to death include a history of vascular disease, patients who had received an older donor graft, and patients with a much longer ischemic time and the presence of delayed graft function. Frailty also played a critical role for access to transplantation, particularly for older patients who are frail. They're 30% less likely to be listed and obtain a kidney transplant. And therefore, our recommendation is that we suggest that we should not exclude patients from kidney transplantation because of age alone, but rather consider the context of other comorbidities such as frailty that may have impact on the outcome about the suitability of transplantation. Of course, this is ungraded, partly because, again, the evidence base to support this recommendation is certainly not high level evidence. So the working group believed that we should take what we call a shared decision-making process for older transplant candidates, understanding their expected survival on dialysis, their expected quality of life on dialysis, and compare that against the expected survival with a functioning graft, and also provide our patients and the caregivers of post-transplant expectations, balancing the risk of over-immunosuppression, such as infection and cancer, against the risk of under-immunosuppression, which include acute rejection and potential graft loss. As we all know, that diabetes and cardiovascular disease are highly prevalent in our transplant candidates. And the risk of MACE in patients with diabetes is much higher than patients without diabetes. This is data from a transplant registry linked to other administrative database in Ontario, Canada. And you can see that the risk of MACE is at least 10-fold higher amount patients with diabetes and kidney disease than patients without diabetes after transplantation, and the risk accelerated progressively over time. The risk of MACE, unfortunately, also is high on dialysis and on the waiting list, and it's relatively constant over time. However, as you can see here with the red line for deceased donor and the blue line for living donor, the risk of MACE increases markedly in early transplant period and declines to a much lower rate than being on dialysis. So understandably, clinicians are highly motivated to screen for cardiovascular disease before transplantation, hoping to prevent these earlier events of death and cardiovascular related events and to improve longer term outcomes. So in this specific guidelines, we recommend patients with type 1 or type 2 diabetes be considered for transplantation, and we provide a grade 1B. However, we also suggest rather than recommend that asymptomatic candidates at high risk for coronary artery disease, such as diabetes and previous coronary artery disease, undergo non-invasive screening. We provide a grade of 2C, and we've done that largely because most of the information are extrapolated from the general population. We also recommend that asymptomatic candidates with known coronary artery disease and asymptomatic should not be revascularized exclusively to reduce perioperative cardiovascular events. And we provide a 1 grade recommendation here. And in the next couple of slides, I will provide the evidence to support these recommendations. So let's look at screenings. For a screening program to be effective, it must adhere to the following WHO criteria. It must be an important health problem, and that the disease should be recognizable at an early symptomatic stage. We understand the natural history of the condition and that there is an acceptable treatment for our patients, and that we'll have a relatively accurate test, and the screening program must be cost effective. And screening should never be just a once-off and should be a continuing process. Now, in the transplant and dialysis population, we know that cardiovascular disease, particularly in diabetic patients, is a very important problem, but all of the other criteria are largely uncertain and unknown because there really isn't a lot of evidence. So what do? We extrapolate data from the general population. Many of you would may be aware of this study that was published in JAMA maybe a decade ago, the DIET study, which is a randomized controlled trial of over 1,100 participants with type 2 diabetes, but no symptoms of coronary artery disease, were randomly assigned to be screened with a stress maybe cardiac scan compared to patients who are not screened. The primary outcomes of this trial is cardiac death and non-fatal MI. And you can see here from the Kaplan-Meier curves, there are no differences in terms of the primary outcomes for MI and cardiovascular related death between the screened and unscreened asymptomatic diabetic patients. Now, understandably, this is a problem because this trial excludes any patients with chronic kidney disease. So we eagerly wait for the results of the CAST trial. The CAST trial is a Canadian-Australian RCT of screening kidney transplant recipients for coronary artery disease, and we're expecting the results to come out in approximately 2 to 3 years' time. What about screening accuracy? Of course, it is a critical important factor to consider when we assess in developing a screening program. This is a very comprehensive systematic review and meta-analyses that assessed the diagnostic test accuracies of various types of screening tests for cardiovascular disease in transplant candidates. And the two most common tests reported in the literature are a stress echo and also a cardiac MIBI scan. The authors here found that the test performance of these two tests are reasonably good and relatively comparable, and hence it is applicable to our screening population. And one of the key criteria for effective screening is, of course, that there should be some form of effective and acceptable treatment for patients once the disease is diagnosed. This is a highly debatable topic of revascularization of coronary artery disease in patients with advanced stage CKD. Now, this is the landmark study just published recently in NIJM. The investigator of this trial randomized 777 patients with stable coronary artery disease and advanced stage CKD to invasive and conservative care. The outcomes of this study are death and non-fatal MI, and you can see here they found that invasive treatment did not effectively reduce the rate of these key primary outcomes. However, can we apply these evidence in our transplant population? Unfortunately, not entirely. We know that early deaths from cardiovascular disease occur largely in the perioperative periods, and the surgery itself is extremely complex, associated with extensive hemodynamic changes, including blood loss and other factors that may potentially influence the outcomes of our patient. What about cancer? In this guidelines, we also assessed the potential transplant suitability of candidates with a history of prior cancer, with a specific focus on the waiting time. This, again, is some work done quite a few years ago, assessing the totality of evidence and recommendations of recommended waiting time for transplantation amounts patient with different types of prior cancer in remission. And as you can see here, there are extensive variability in these recommendations, although there are some consistency. For example, all 5 guidelines recommended patients with metastatic melanoma not for transplantation. In most cases, a waiting time between 2 to 5 years is recommended depending upon the grade, the histology of the original cancer diagnosis. And why is that? So this is work done by a Norwegian registry analysis looking at patient survival amongst those with and without prior cancer. And again, you can see in the Kaplan-Meier curve, there are no substantial differences in the overall survival. However, there is a much higher risk of death, and you can see a clear separation in these 2 curves for cancer-related death, with an excess risk of approximately 1.5 times amongst those with prior cancer compared to those without. A more recent systematic review assessing the prevalence of cancer recurrence after transplantation in patients with prior cancer indicated the overall recurrence rate of approximately 1.6 per 100 person years. The absolute risk remained relatively small, but as you can see here from the I-square of this systematic review, there are substantial heterogeneity between studies, population bases, and how they assess the actual estimates. And you can also see here that in a subgroup of these patients, those who have waited for over 5 years before transplantation, there is a much lower risk of disease recurrence. Unfortunately, this meta-analysis did not account for the stage or histological status of the prior cancer. Obviously, these are observational studies, so they're subject to major selection and confounding bias. So our current recommendations is that we recommend candidates with acute malignancy be excluded from transplantation, except for a few cases. For example, patients with indolent and low-grade cancer, such as prostate cancer, superficial non-melanoma skin cancer, and incidentally detected renal cell carcinoma of less than 1 centimeter in diameter. The timing of kidney transplantation should be dependent upon the cancer type and stage at initial diagnosis. We also recommend no waiting time for some cancer, and these are highly selected group, including SCC and BCC of the skin, melanoma in situ, small renal cell carcinoma, and low-grade prostate cancer. But we emphasize that the decision about transplantation for candidates in remission from cancer should really be a collaborative effort between the oncologist, the nephrologist, patients, and more importantly, the family. And I would recommend you to go through the table 14 of the guidelines, because it provides the comprehensive recommended waiting time for cancer remission and transplantation. So when considering retransplantation in these potential candidates, we recommend the clinicians, the candidates, and patients must clearly communicate the risk with their patients, both the overall survival and cancer-free survival, as well as the risk of death and cancer recurrence with immunosuppression. And what happens with the survival if the patient do have the cancer recurred, and balancing against that against the quality of life and survival on dialysis, with survival, with the transplant, with and without cancer recurrences. More importantly, patient preferences and the perspective of what specific treatment should be in the discussion. Last but not least, I'd like to have a discussion about non-adherence. Non-adherence is an extremely complex issue in transplantation because it can lead to complications such as acute rejection and subsequent graft loss. And the reasons for non-adherence are multifactorial and may be related to social, psychological, economic, physical, and financial factors. And often these factors are unintentional, and particularly in times of COVID, where people are under a lot of different stressors and anxiety and financial burden. And obviously certain groups may have a greater tendency to be non-adherent than others, such as the young adult population. So our recommendation is to assess adherence, but also most importantly, the barriers of non-adherence before transplantation, and ensure that appropriate education and pre-transplant counseling are provided. We should not exclude candidates with history of non-adherence from retransplantation. So in summary, transplant assessment is extremely complex. This guideline provides recommendations for evaluation on the individual aspects of a candidate's profile, taking into account the risk factors as well as their comorbidities. This guideline is definitely intended to be global. We're hoping that transplant professionals to assimilate all relevant data that is important to the specific individual and apply this in the local context, and make an overall informed judgment and decision on the candidacy for transplantation. Last but not least, I'd like to extend my sincere thanks to the entire working group, who was an amazing group of transplant professionals and academics who made these guidelines a reality. Thank you so much.
Ben Sayın Doktor Germaine Wong'a teşekkür ediyorum.
I would like to thank Dr. Germaine Wong. Now I'm inviting the second speaker of the day, Dr. Nikhil Tandon. He is going to make a speech on diabetes and the management of chronic kidney disease. He is going to talk about 2020 diabetes management in CKD. The floor is yours, Dr. Tandon.
Right. Thank you very much, and a very good morning to everybody. It's indeed a both pleasure and a privilege to be able to participate in this meeting of the Nephrology Society in Turkey. And my remit for the next 20 or 25 minutes is essentially to share with you the recently published diabetes management guidelines in patients with chronic kidney disease, which came out from the Kidney Disease Improving Global Outcomes group, or the KDIGO. And this was just published recently in Kidney International. To put on record first, that this presentation essentially summarizes work which is done by the work group, which is chaired by Ian DeBoer from the University of Washington and Peter Rossing from the Steatodiabetes Center, and had a group of endocrinologists, nephrologists, primary care physicians, and also patient representatives to give a flavor. And we had tremendous support from the evidence review team based out of Sydney, Australia, who systematically went through literature, summarized the information, and made the evidence available to us so that we could present it to you. The scope of the clinical practice guideline included both type 1 and type 2 diabetes, include all stages of chronic kidney disease, including kidney transplant recipients and dialysis, and predominantly focused on interventions addressed with through randomized controlled trials, whether it was lifestyle, pharmacotherapy, or in health systems. We did not refer to interventions which are covered in other guidelines from KDIGO, which included blood pressure or lipids, prevention and screening, and obviously topics of which we had insufficient evidence. I think it was important to put on record that we had certain challenges, and the challenges were when the evidence was not as robust as we'd like, how to balance the need for providing a recommendation with the need to provide a recommendation with adequate evidence. And then, of course, the issue about trying to address the guidelines across a whole range of patients. So type 1 and type 2 diabetes, in which there may have been subtle differences, but specifically stages of chronic kidney disease, which is on some occasions a little difficult to reconcile early stage CKD and late stage CKD and give the same set of guidelines. And we've tried to identify and communicate that accordingly. And obviously the same happened with end stage kidney disease and transplant recipients. Professor Wong has already taken you through the way we've did the grading. So the same 1 and 2, A, B, and C and D was the grade methodology which was used, and I will not repeat that. But there are 5 essential areas which are covered in these guidelines. 1 on comprehensive care in patients with diabetes and CKD, and I'll largely focus on RAS blockade. The second was monitoring, the methods of monitoring and targets for glycemic control in patients with diabetes and CKD. A little bit about lifestyle interventions, specifically about protein intake and sodium intake. A spare amount of time was spent on the sort of anti-hyperglycemic therapies which are advisable in this instance. And of course, a final sort of a clinical health system recommendation with regards to approach to management. We've also decided to include an entity called practice points. So there are recommendations which are based on clear evidence. Practice points are based on evidence which perhaps doesn't meet the threshold for a strong recommendation, but these were suggestions by the work group which are clinically relevant and which are could be taken on board by practicing clinicians depending on the context of the patient that they see. So the practice point in the comprehensive care really suggested that in patients with diabetes with CKD, your overall emphasis is looking at cardiovascular and renal outcomes. And therefore, glycemic control, RAS blockade, blood pressure control, lipid management, overall lifestyle and physical activity, smoking cessation, nutrition, and aspirin were the key aspects. And of this, I will predominantly cover only one area, which is the area about the treatment with an angiotensin converting enzyme inhibitor or an angiotensin 2 receptor blocker, the ACE and ARBs, and that this should be initiated in people with diabetes, hypertension, and albuminuria, right? And the first thing, therefore, that comes through is that we did not find still adequate evidence to suggest this for primary prevention, but clearly in those with diabetes, hypertension, and albuminuria, this needs to be initiated. And the second part was that these medicines should be up-titrated to the highest approved dose that is tolerated by the individual. This sort of flow diagram would be very, very familiar to the nephrologists in the audience, but I will, for the sake of completion, still take you through this. So as mentioned, that in people with diabetes, hypertension, and albuminuria, the recommendation was to start an ACE inhibitor or an ARB. And once you do that, or you change the dose, the recommendation was to monitor serum creatinine and potassium after 2 to 4 weeks. If you encountered normal cholemia and the increment in creatinine was within 30% of what was seen at baseline, the recommendation was to continue increasing the dose till you reached a maximally tolerated dose, or you encountered a problem in the form of either hyperkalemia or a substantive increase in creatinine. The issue with hyperkalemia, which we tried to bring out in this particular recommendation, was that if you encounter hyperkalemia on either initiation or on dose enhancement, please look at other contributing factors, including the diet, including concurrent diuretic use, soda bicarb or GI cation exchanges, and address those rather than making an effort to reduce ACE or ARB or stopping them. So the plan was to try and abrogate the hyperkalemia by bringing changes in other medication, and only if that didn't fail, reduce the dose or stop ACE or ARB as the last resort, because they are definitely beneficial in this group of patients. If, however, we encountered a more than 30% increase in creatinine, it was obligatory to review for causes of acute kidney injury, avoid dehydration and concurrent diuretic use, and also rule out a concurrent renal artery stenosis, which could be responsible for this sudden increase in creatinine. A very simple single recommendation for tobacco was that if in individuals who are taking tobacco in any form, whether it is smoke or smokeless, they should be recommended for an absolute and immediate cessation. And that was a very, very strong recommendation from the group. We spent a fair amount of time on the issue about glycemic monitoring and the targets for control. It was clearly recognized that in people that hemoglobin A1C continues to remain a preferred monitoring mechanism, that we know that blood glucose and hemoglobin levels contribute to the HbA1c, while CKD can actually result in a high bias, that is a false elevation, which could be because of carbamylation of hemoglobin or because of metabolic acidosis, or in some instances, even a low bias because of the presence of anemia, the treatment of anemia using iron supplements, transfusions, or erythropoiesis stimulating agents. And therefore, we need to understand these before taking a decision. But very, very clearly, especially in early stage CKD, monitoring by A1C at least twice a year. And if you have unstable control or you had changes in medication, up to 4 times a year was what we really recommended. Accuracy and precision of A1C measurement declines with advanced CKD, and that is even more marked in individuals who are on dialysis. There's several practice points which we actually recommended out here, that entities which include continuous glucose monitoring, which can result in generation of an index glycemia score, should be considered, especially in those individuals in whom HbA1c is not concordant with directly measured blood glucose levels or clinical symptoms. Self-monitoring of blood glucose or continuous glucose monitoring by newer devices should be considered, especially when you're using agents in which there's a high risk of hypoglycemia. For patients with CKD and type 2 diabetes who either choose not to do daily glycemic monitoring by SMBG or CGM, or they are resource constrained, please consider an anti-hyperglycemic agent or agents that pose a lower risk of hypoglycemia. And finally, that we have increasing availability of continuous glucose monitoring devices, which have several functionalities, and these may offer advantages to certain patients, but this was as yet not considered to be strong enough to make it into a clear recommendation, but definitely as a practice point. And this really summarizes this whole issue of HbA1c and a CGMI in patients with CKD. Early stage CKD from 1 to 3B, twice a year in everybody, and up to 4 times a year if they are not achieving targets for control or there's a change in therapy. The reliability is good in this category of patients and is strongly recommended. You can try CGMI in certain circumstances, and it may be occasionally useful, but it's not recommended for all. In late stage CKD in 4 and 5, including people on dialysis or in transplant recipients, you can continue to try A1C, but recognize the frailty and fallibility of this particular test, and therefore now start looking at other devices for continuous monitoring or SMBG, which may be much more useful in this category of individuals. And this particular slide actually sums up the entire recommendation or suggestions that we had for individualizing HbA1c targets. We realized that a single target recommendation would not be appropriate because several factors will contribute to it, and therefore we gave a range of a tight control of less than 6.5 in certain individuals and circumstances and less than 8% in other individuals. And the conditions which contributed to the decision making are listed on the left. So as in individuals with early stage CKD who have few other microvascular complications or comorbidities, who are young, whose anticipated life expectancy is long, who have resources available for hypoglycemia management, who have intact hypoglycemia awareness, and who have treatment with a low propensity to cause hypoglycemia, tight control is recommended. In contrast, later stage CKD, many other comorbidities, older individuals who have anticipated short life expectancy, who do not have resources for hypoglycemia management, who have increasing hypoglycemia unawareness, and who have treatment with a propensity for causing hypoglycemia, looser control, an A1C of target of 8% is advocated, and everybody then falls in this particular range. And this, I think, is a very important recommendation to keep individualizing the control of glucose. This is what I really mentioned, and this may be facilitated by SMBG or CGM in certain instances, and CGM metrics, if you're using this, including time and range and time and hypoglycemia, may actually be supporting in deciding glycemic targets. For the lifestyle interventions, as I said, we looked at diet overall, protein, and sodium. The general dietary advice for people with diabetes and CKD remain fairly consistent with a good, healthy, diabetic diet, if I may use the term, high in fruits, vegetables, whole grains, fiber, legumes, plant-based proteins as a preference, unsaturated fats and nuts, and a de-emphasis on processed meats, refined carbs, and sweetened beverages, and a plate model represents the same. But the two areas where we spent a lot of time and gave a recommendation was protein intake, which was maintaining a protein intake of 0.8 grams per kilogram body weight for those with diabetes and non-dialysis CKD. But those on dialysis, especially on peritoneal dialysis, this recommendation was increased to between 1 and 1.2 grams per kilograms per day. In terms of sodium, the recommendation was less than 2 grams of sodium per day, which is the equivalent of 5 grams of salt. And the rationale for that was very, very clear. There is very high level of evidence that decreased sodium intake reduces blood pressure, and there's moderate quality evidence that a decreased blood pressure reduces cardiovascular disease and reduces risk of stroke, though the evidence of impact on progression of CKD is possibly weak, but nonetheless, this recommendation was good for an overall survival. For physical activity, and I will not take you through in more detail because you can see this is a 1D level, that we recommend the same thing which we recommend for all people with diabetes, 150 minutes a week. Identify if the person is sedentary, identify the fall risk and comorbidity burden. If the fall risk is high and there are lots of comorbidities, only a gentle escalation is recommended. If they're otherwise healthy, there is low or minimal fall risk and low comorbidities, escalation to reach 150 or more minutes per week is what is recommended. However, if there is a concern about fall risk, you must recommend muscle strengthening activities to see if that can then enable the patient to indulge in a higher level of physical activity. The substance of the anti-hyperglycemic therapies is what's going to take a large part of the rest of my talk. Obviously, pharmacotherapy has to be layered over physical activity, nutrition, and weight loss. Metformin remains the agent of first choice as long as the estimated GFR is 30 milliliters per minute per 1.73 square meters. And that is an agent of first choice across board. The moment eGFR dips below 30, discontinue therapy. If somebody is on dialysis, discontinue. And I'll come to this in much more detail in the next slide. The second agent, which is now gravitated towards a high recommendation, are SGLT2 inhibitors, especially because a slew of studies over the last couple of years have demonstrated not only cardiovascular benefits, but also benefits in terms of renal outcomes. Again, SGLT2 inhibitors to be given in individuals who have an eGFR more than 30. If they are less than 30, do not initiate. If they're on dialysis, do not initiate. However, if they are started in individuals who had an estimated GFR of more than 30, but they dip to below 30, there is still something to be said about continuing, because recent data on people with 20 and 25 milliliter per minute suggests that there may be a continued benefit with therapy. However, do not start it if individuals have already got an eGFR less than 30. The next set of agents was GLP-1 receptor agonists. And the reason why they are preferred is that they have no or low tendency to cause hypoglycemia, and again, cardiovascular benefits. And then the rest of the agents, including DPP-4 inhibitors, insulin, sulfonylureas, TZDs, and alpha-glucosidase inhibitors come lower down in this particular list. Now, this particular diagram, and I'll spend a minute or two on this, really summarizes everything well. The innermost circle identifies in different pies, preferences, comorbidities, or other specific characteristics. The next concentric circle and the corresponding pie suggests the more suitable medication, and the outermost concentric circle in the corresponding pie suggests less suitable medication. Let me start one by one and take you through this. If you look at this pie, which has which talks of if the concern is a high risk for atherosclerotic cardiovascular disease, and this is of course add-on therapy to those who've already received metformin and SGLT2 inhibitors. In those with a high risk of CVD, GLP-1 receptor agonists will be drugs of choice because of proven cardiovascular benefits and a range of cardiovascular outcome trials. If you need potent glucose lowering, then again, GLP-1 receptor agonists and or insulin would be preferred, and the relatively milder agents like TZDs or DPP-4 inhibitors would be less suitable. If you are concerned about hypoglycemia because of failure of monitoring, hypoglycemia unawareness, etc., then again, agents less likely or unlikely to cause hypoglycemia, including GLP-1 receptor agonists, DPP-4 inhibitors would be agents of choice. Sulfonylureas and insulin drop off the chart here. If the patient says, I do not want injectables, I only want oral medications, obviously GLP-1 receptor agonists and insulin goes out, whereas DPP-4 inhibitors, TZDs, sulfonylureas come back up. There are now GLP-1 receptor agonists like semaglutide, in which oral therapy is also available. If weight loss is preferred, GLP-1 receptor agonists are preferred, whereas sulfonylureas, TZDs, and insulin are not preferred. If cost is important, so say for somebody like my patient population, I work in a publicly funded institution with low and low middle class clientele, their cost is very important. Then agents like sulfonylureas, which are long-lasting medication, which have been around for a long time, TZDs would be agents of choice as opposed to GLP-1 receptor agonists and some DPP-4 inhibitors, which are still on patent. The moment you're below an EGFR of 15, actually, you're looking at some agents like DPP-4 inhibitors like linagliptin, insulin, and TZDs, but then GLP-1 receptor agonists have not been tested in this population, so they go out. If fluid overload is a matter of concern, then GLP-1 receptor agonists become agents of choice, and TZDs, which actually cause fluid retention, go out. And this is a figure from the guidelines. You should be able to access it without difficulty. This really sums things up in one snapshot. There is a lot set out here, but what is essentially a little bit more in detail is that metformin remains the first line of therapy as long as at the time the patient comes to you, their estimated GFR is in excess of 30. You can even give it in transplant recipients provided they meet the same EGFR threshold. Monitoring of patients as long as EGFR is more than 60 continues as usual. Below 60, the monitoring changes to more frequent, and the next slide will show you that. Adjust the dose of metformin when they dip below 60. And the other point which we often forget is that if somebody has been on metformin for 4 years or more, there is a higher likelihood of B12 deficiency, and therefore B12 measurements should be done. And this again summarizes the story on metformin fairly well. If EGFR is less than 30, do not start or stop. If it's less than 60, we further bifurcated it to between 30 and 45 and 45 and 60. If it's more than 60, you're on safe zone. You can start with 500 or 850 milligrams once daily, either immediate or extended release, and can up titrate at even as early as 7 days. This category of individuals can be monitored even on an annual basis for their creatinine, just like they do it for all people with diabetes. And then at the end of that, at 4 years, you also do that for B12. If the EGFR remains more than 60, the same process can be continued. If the estimated GFR is between 45 and 60, it's obligatory to increase the frequency of monitoring to at least 6 monthly and ideally 3 monthly. If it remains there, the same monitoring frequency and the same dose escalation can continue. Once it falls below 45, you should initiate at only half the dose mentioned in this box, and you should also titrate it maximally to only half of what is the maximum recommended dose. So if you normally give 2 grams as your maximum dose of metformin, it should stay to 1 gram and not more than that. And this again summarizes fairly well what the metformin recommendation is. SGLT2 inhibitors, as I said, have climbed up on the charts because of the evidence on their cardiovascular benefits and on renal outcomes. It can be added to other anti-hyperglycemic mechanisms if the glycemic target is not being met and you are happy to reduce sugar control. If you find that a person is on metformin and was already started on another anti-hyperglycemic agent, you may also in this instance consider adding SGLT2 inhibitors. And if you're concerned that this may cause a dip in the sugars and may expose the person to hypoglycemia, it is preferable then to down titrate other medication. So you retain metformin unchanged, you bring in SGLT2 inhibitors, but you down titrate other anti-hyperglycemic agents, especially insulin or sulfonylureas, which may contribute to development of hypoglycemia. As I already mentioned on a couple of occasions, there's a whole range of data on the benefits of SGLT2 inhibitors for CV death, for non-fatal MI, non-fatal stroke, hospitalization for heart failure, and for renal outcomes. And therefore, they are increasingly becoming important agents as long as cost is not an impediment for the patients. So this really summarizes what I said before. meet an individualized, if the person is meeting an individualized glycemic target, can you lower it by adding an SGLT2 inhibitor? No, then reduce the agent of the current anti-hyperglycemic medication other than metformin and add the SGLT2 inhibitor. If you think there's scope for adding it without causing hypoglycemia, then simply add an SGLT2 inhibitor. So really, it's a fairly strong recommendation for bringing SGLT2 inhibitors at the number 2 position after metformin. It is, however, important to understand, especially in certain scenarios where there may be a prolonged fast. There are rituals of fasting which are observed by people in many religions. That prolonged fasting or critical medical illness is not a good time to give SGLT2 inhibitors because they are at risk for euglycemic ketosis. If there is already a risk for hypovolemia, and the person is on a thiazide or a loop diuretic, you may consider reducing the dose of those agents because the SGLT2 inhibitors will also cause some degree of osmotic diuresis. It's important to flag a point that there may be a transient reversible decrease in EGFR with commencement of SGLT2 inhibitors, and that's not an indication to discontinue therapy, right? Once an SGLT2 inhibitor has been initiated at a higher EGFR and the person dips to below 30, you can still continue because of recent data which suggests a continued benefit in renal and cardiovascular outcomes. These agents have not yet been studied in kidney transplant recipients and therefore are not recommended as yet. The third agent, which we spent a lot of time and decided it's worth looking at in much more detail, and therefore the recommendation is if somebody is not meeting their prescribed targets despite metformin and or SGLT2 inhibitors, the next agent would be a GLP-1 receptor agonist. So exenatide, liraglutide, dulaglutide, semaglutide. We prefer those in which there's a documented CV benefit to minimize their gastrointestinal side effects, which are very common, virtually if not universal. Start with a small dose and up titrate. They should not be combined with a GLP-1 receptor agonist, not be combined with a DPP-4 inhibitor. On their own, these agents have a low risk for hypoglycemia, but you must be careful that concurrent medication is still on and you may need to down titrate the dose of insulin and or sulfonylureas if the patient is on that. This is just listing the available GLP-1 receptor agonists. They could be once daily, twice daily, once weekly. No dosage change is required as long as you are at an EGFR of 30, which is what is recommended. With dulaglutide, there are some data that you can use it even as low as an EGFR of more than 15. And the last sort of group of recommendations were on the management of patients in terms of this clinic structure or the hospital structure. And what our recommendation was a structured self-management educational program to be implemented for care of people, and the system in which they are being treated should consider implementing this program, looking at improving the diabetes-related knowledge, improving self-management, adoption of healthy lifestyle, improving vascular risk factors, including aspirin cessation of tobacco, increasing engagement with medication glucose monitoring and complication screening, reducing the risk to prevent diabetes-related complications, whatever is required, and a general improvement in quality of life. And therefore, there was a recommendation to policymakers and institutional decision makers to ensure a team-based integrated care which is focused on risk evaluation and patient empowerment to provide comprehensive care and not just individual clinics. So I'm going to stop here by giving you an overall summary. These guidelines were just published recently in Kidney International in October. They provide fairly comprehensive recommendations on and practice points on comprehensive care, glycemic monitoring and targets, lifestyle interventions, anti-hyperglycemic therapies and approaches to manage the patient. They emphasize the need for patient-centered decision-making, individualized targets, individualized methods of monitoring, strong recommendations and control of risk factors with regard to RAS blockade, individualized glycemic targets, emphasis on specific agents, especially metformin, followed by SGLT2 inhibitors, and personalized targets, and for healthcare organizations, strong recommendations for supporting a coordinated care. And with these, I will thank you so much for your patient hearing, and we'll stay back for the interactive session later on to answer any questions as they arise. Thank you once again. Thank you.
Doktor Tandon'a ben de çok teşekkür ediyorum.
I do thank you, Dr. Tandon. And in terms of time, I would like to leave the floor to Mr. Tomson rapidly. He retired last year, but because of COVID pandemic, he got back to work. We are going to listen, watch the video of his presentation, and he will be with us in the live Q&A.
Good morning. My name is Charlie Tomson.
Good night.
I'm a recently retired consultant nephrologist, most recently working in Newcastle upon Tyne in the north of England. I'm speaking to you from my own home in Northumberland in the north of England, and I hope that wherever you are in Turkey or elsewhere, that you're safe and well and surviving the rigors of this current pandemic. It's a great honour to be invited by the Turkish Society of Nephrology to give a presentation on their KDIGO Blood Pressure and Chronic Kidney Disease Guideline, which we've been working on for some time and which is due for publication. Recording a presentation on Zoom without a live audience is a new experience for me, and I hope that you will forgive me if my presentation is at times stilted, but I'll try to make it as clear as I can. I have no disclosures, and in particular, I've had no payments, honoraria, or any other form of benefit from pharmaceutical companies for at least the last 10 years. This is a picture of the members of the Blood Pressure Guideline Update Work Group. We were drawn from various parts of the world, a significant number of North Americans, some Canadians, 2 Europeans, myself and Johannes Mann, the co-chair, from Brazil, from China, and the evidence review team from Australia. Our task was to revise the existing 2012 KDIGO guideline, mostly in light of the SPRINT trial and also the SBS trial and several other bits of evidence that have emerged since that guideline was produced. And to do this, we commissioned the evidence review team, which was the Cochrane Kidney and Transplant team based, as I say, in Australia, to review the previous literature and any subsequent literature that has appeared, looking at these outcomes, the critical outcomes and the important outcomes. The evidence review team focus whenever they can on randomized controlled trial evidence, but in some questions we've had to rely on weaker evidence than that. These were the populations that we studied, the interventions that were looked for in the literature, the comparators, and the outcomes. And you can see that in the question of how to measure blood pressure, the search was extended to studies in the general population because there just weren't enough studies amongst patients with CKD to be informative. In patients with CKD, we looked at various blood pressure targets and looked to see what the literature told us about the effects of the blood pressure targets on the outcomes that I've mentioned, and the same for antihypertensive medication and for diet and exercise. The evidence was assembled using software developed by the MAGIC app team. And I've given you the websites there for the MAGIC Evidence and MAGIC App websites. This is electronic guideline software, which we're publishing in KDIGO, and it allows readers to see much more clearly than previously how the evidence translates through to recommendations. We hope that it'll improve the accessibility of guidelines because of digital publishing, and this type of software allows for guidelines to be imported into clinical decision support systems within electronic medical records. We hope that it will also allow guidelines to be updated much more easily and with more agility in the future, rather than waiting for a 5 or 7 year gap between one set of guidelines and another. And as I'll show you later in my presentation, the software allows for the generation of patient decision aids, which are particularly useful to support shared decision making. GRADE offers 2 levels of guideline: a recommendation, which is a hard or a strong recommendation, in which most patients in the situation being described would require and want the recommended course of action, and only a small number would not. For clinicians, this means that patients should receive that course of action unless there's a very good reason otherwise. And for policymakers, it means that the recommendation can be used as or can be considered for quality measurements or performance measurements. Suggestions are weaker because the evidence is in general more balanced, not necessarily because the evidence is weaker, but because the evidence of benefit is more balanced and more nuanced. And it may be that people in particular clinical situations or having particular views and preferences about their own health and priorities might make different decisions. And this is where guidelines are particularly useful to use in conjunction with shared decision-making patient decision aids. GRADE has 4 grades of strength of evidence, from very high to very low, and obviously we're able to make more confident recommendations when the evidence is very good. The work group was formed between April and May of 2016 by invitation from the co-chairs Johannes Mann from Germany and Alfred Chong from Salt Lake City in Utah. They in turn have been appointed by the KDIGO command structure. And the first thing we did was to agree on a scope for a controversies conference, which was held in person in Edinburgh in September 2017. And the paper that arose from that conference, where we discussed many of the issues, which then became the questions that we commissioned the evidence review team to look at, was published in KIA in 2019. The work group has only met physically once in January 2019 in New Orleans, and this was well before COVID, so this was just a cost and efficiency decision. All of our other work has been done by video conference, telephone conference, and email. A draft guideline for public review was issued at the beginning of February of this year, and the guideline was then extensively reviewed in the light of the public comments. Although not all the comments were of course accepted, because there was a wide range of views expressed. The full guideline was submitted to KI supplements just recently, along with an executive summary submitted to KI, and we hope they'll be published very soon. The guideline will also be published, however, on the Magic App website, which I've mentioned earlier. These are the headline recommendations. All treatment decisions related to blood pressure lowering treatment, whether that be by diet, exercise, or blood pressure treatment, or some other intervention, should be based on office standardized resting blood pressure measurements. And I'll come back to a definition of that shortly. Ambulatory and home blood pressure measurements may be used to complement standardized office blood pressure measurements, but should not be used as the primary measures by which treatment decisions are made. Patients with chronic kidney disease and high blood pressure should be advised to aim for a dietary salt intake, sodium chloride intake, of less than 90 millimoles per day, and they should be advised to achieve aerobic exercise for at least 150 minutes per week. The target for patients with chronic kidney disease should be a systolic blood pressure of less than 120. Transplant patients have a practice point applied to them, aiming for a blood pressure of less than 130/80. And the difference for those 2 recommendations I will come back to. Children should be treated to a daytime mean ambulatory blood pressure less than 50th percentile for the individual child. The use of ACE inhibitors or ARBs is recommended in CKD G1 to G4 with albuminuria A2 to A3, and the strength of those recommendations varies depending on the presence or absence of diabetes and the degree of albuminuria. Kidney transplant patients requiring blood pressure lowering treatment should be offered either a hydropyridine calcium channel blocker or an angiotensin receptor blocker. And the combination of ACE with ARB, ACE with direct renin antagonist or ARB with direct renin antagonist should be avoided because of the strong evidence that the harms in those situations outweigh the benefits. Why should we lower blood pressure in patients with CKD? This may seem like an obvious question, but let's just discuss it very briefly. There are two main reasons. The first is to reduce mortality and morbidity, largely via the reduction of cardiovascular disease, for which hypertension is a very potent risk factor. And the second is to reduce the risk of progression to end-stage kidney disease. And we know from much smaller trials in selected populations with potentially progressive chronic kidney disease that blood pressure lowering treatment does slow the rate of progression. We don't know which of these two outcomes matters more to patients with CKD, but it's reasonable to expect that most patients would prioritize all-cause or cardiovascular mortality over the risk of end-stage kidney disease, because the great majority of patients with early CKD are likely to die early from cardiovascular disease, and much, much, much less likely to progress to needing renal replacement therapy. So I've given you one study here from Robert Foley showing that in a large sample of Americans with chronic kidney disease, the risk of death was 45.7 times higher than the risk of needing renal replacement treatment. Standardized office blood pressure measurement is likely to be the most controversial of all of the recommendations made in the blood pressure guideline. But we strongly, strongly believe that this is very important. And I'll explain why very briefly, but just to tell you what we mean by standardized office blood pressure measurement, the patient should be prepared carefully. They should be offered 5 minutes of relaxation before any measurements of blood pressure are done. They should be seated with their feet on the floor and their back supported comfortably. They should have avoided caffeine, exercise, and nicotine in the preceding 30 minutes at least. They should have an empty bladder so as to prevent discomfort from a full bladder. There should be no clothing under the blood pressure cuff, and nobody should be talking to the patient during or around the time of the blood pressure measurements. A proper technique for blood pressure measurement should be used, and it doesn't really matter whether this is an oscillometric or an automated machine. What matters is that it's validated, calibrated, the arm is supported at heart level, and the correct cuff size is used. As you know, when first assessing a patient with kidney disease, or for that matter, hypertension without kidney disease, blood pressure should be checked in both arms to exclude the rare but important situation where there's atherosclerotic disease in one arm that leads to a lower reading. And the arm that uses that gives the higher reading should be used for all subsequent measurements. There should be separate repeated measurements by at least 1 to 2 minutes. For auscultatory readings, the cuff should be inflated to 30 millimeters above the point at which the radial pulse is obliterated and deflated at 2 millimeters per second using the first and fifth cough sounds. And the average of the readings obtained should be used in decision making. The rationale for this is that all outcome trials of blood pressure targets have used standardized blood pressure measurements. So the only informative evidence has used measurements along the lines of the ones that I've just described to you. We know that home blood pressure measurements and ambulatory blood pressure measurements often give lower readings than standardized blood pressure measurements, but that's hugely variable from patient to patient. So you cannot use a home or ambulatory value to predict what the standardized office blood pressure measurement would be in an individual patient. We only know the differences between populations. Casual office blood pressure, without the precautions that I've outlined in the previous slide, are so variable that the use of such measurements to decide on prescription of blood pressure lowering treatment is indefensible in our view, and risks serious overtreatment in those patients whose blood pressure is high because they're talking, uncomfortable, or have just rushed in from the car park and had the blood pressure measurement without any rest, for example. One piece of research, and there are many that can be used to explain why this is so important, was done by Rajiv Agarwal in the United States amongst a patient group, largely men, but there's no reason to expect that these findings would be different in women, in which research grade standardized office blood pressure was compared to routine clinic, without those precautions, and also compared to the ambulatory blood pressure measurements that were also available in this group of patients. And you can see that there's both bias and huge variation in the limits of agreement. So if we were to compare research grade, that's standardized office blood pressure, to routine unstandardized blood pressure, research grade gives a blood pressure measurement on average 12.7 millimeters of mercury lower than routine systolic blood pressure. That's a big difference. But look more at the limits of agreement. It could be as much as 46 millimeters lower or 20.7 millimeters higher than the standardized blood pressure measurement. And that is a remarkable degree of variation. And Rajiv also showed that the strength of the association between standardized and daytime ambulatory systolic blood pressure with left ventricular hypertrophy as a marker of target organ damage was very similar. And those strengths were much stronger than the association between routine blood pressure and LVH. Standardized blood pressure is more consuming than casual blood pressure, but just ask yourself, would you accept this degree of bias and inaccuracy for measurements of creatinine, potassium, body weight, age, or any other measure on which you base clinical decision making? And I put to you that the answer is nearly certainly no. So the rationale for the target blood pressure of less than 120 amongst patients with CKD is that most patients would place a much higher value on the avoidance of cardiovascular morbidity and mortality than the avoidance of end-stage kidney disease. And we have large outcome trials demonstrating benefits for cardiovascular disease in patients with non-diabetic CKD from SPRINT. The ACCORD trial showed a marked reduction in stroke, which is a pre-specified endpoint in that study, but only included 401 patients with an eGFR less than 60. ACCORD was a complicated design because it also had a factorial randomization to standardized versus intensive glycemia control. And the intensive glycemic arm was terminated early because of evidence of harm. If you look at the benefits of blood pressure 120 in the standard glycemic arm, they're very similar to the magnitude and direction of those seen in SPRINT. So it could be argued that ACCORD showed the same thing as SPRINT, but didn't show it clearly because of the complication of the results by the intensive glycemic arm control. Intensive glycemic arm, I apologize. Meta-analyses have also demonstrated that the reduction of cardiovascular risk is proportional to blood pressure lowering throughout the range of blood pressure lowering in the studies done so far. Although some of the meta-analyses, including the blood pressure lowering trialist collaboration, the Etihad meta-analysis listed below, show a slightly lower proportional risk reduction in the presence of either chronic kidney disease or diabetes. The benefits of blood pressure lowering to a blood pressure target of less than 120 are summarized on the MAGIC app software that I mentioned earlier. And you can see that the certainty is low because we only have one trial, the SPRINT trial, plus ACCORD, giving us data. And although SPRINT was a very high quality study, the methodology says that if there's only a small number of trials showing the effect, one cannot be completely certain. But all-cause mortality, cardiovascular mortality were both significantly reduced amongst patients with chronic kidney disease randomized to blood pressure target of less than 120. And there was no increase in the follow-up available to us from SPRINT of end-stage kidney disease. There were, however, more episodes of acute kidney injury, although whether that was acute kidney injury as we really understand it, or to at least some extent, hemodynamic changes caused by a lower blood pressure, which may well be protective in the long term, cannot be said with certainty. We can also translate these risk reductions into pictures, which some patients find helpful, so that you can see that there are 14 fewer patients dying over follow-up with a blood pressure target of less than 120. The Malhotra meta-analysis of trials of intensive versus less intensive blood pressure lowering was confined to patients with CKD. And this meta-analysis concluded that the more intensive versus less intensive blood pressure control resulted in a 14% lower risk of all-cause mortality. And that finding was consistent across multiple subgroups. The kidney transplant practice point is slightly different because there is no informative randomized controlled trial evidence for optimal blood pressure target amongst patients with kidney transplants. We know, however, that kidney transplants patients value graft survival very highly, and many would prefer to die with a functioning graft rather than return to dialysis and live a bit longer. And so the prioritization is very different in this group of patients. And we also know that intensive blood pressure control was associated with a slightly higher rate of loss of eGFR over time in SPRINT and a higher risk of AKI, as I demonstrated just now. And it's possible to speculate, but not prove, that single denervated kidneys, transplanted kidneys, may be at higher risk from a very low blood pressure. And on these grounds, the group that put together the kidney transplant chapter have developed this practice point that patients should be offered a target of less than 130 over less than 80. So I talked about the risk of progression, and this is a table from the Magic App site, which is largely derived from SPRINT and shows that there are more patients with a 30% loss of GFR or a 40% loss of GFR amongst those randomized to more intensive blood pressure control. We do know, however, that most of this initial drop in GFR is not associated with markers of tubular injury, and it's associated with a reduction in albuminuria. And those two findings suggest that at least the initial drop in GFR is due to altered intrarenal hemodynamics, which may be beneficial in the long term, at least in proteinuria patients. However, we also know that the overall rate of decline, even after the first initial fall, is higher in patients randomized to more intensive blood pressure control. This difference is small, and it would take 20 years to cause a 3 ml per minute difference in GFR between intensive and less intensive blood pressure control. But nevertheless, this is of concern to patients who really value graft survival over all else. The rationale for the recommendation for blood pressure control in children is derived entirely from the ESCAPE study, which randomized children to treatment based on ambulatory blood pressure and concluded that children should be offered treatment to ensure that they get down to the lowest, so below the 50th percentile for age, sex, and height. The challenges for implementation are significant. The guideline that we have issued conflicts with other national and international guidelines, most of which have been much more conservative. The reasons for the conservatism are varied, but have been largely because international guideline groups have been reluctant to recommend standardized office blood pressure and have therefore gone for a higher target to reduce the risk of overtreatment. We debated this at great length in the working group, and we are aware that the resource implications of requiring standardized office blood pressure measurements are not insignificant. In a high throughput chronic kidney disease clinic, and this may be even more of a problem in low resource countries and middle income and low income countries, standardized office blood pressure measurements will interrupt the flow of patients quite significantly. And in addition to that, we're aware that intensive blood pressure control requires, in the great majority of cases, more drug treatment than would otherwise be the case. And that has direct costs, as well as the indirect costs that sometimes come with particular types of drug treatment, including the requirements for monitoring of electrolytes and creatinine, for instance, after initiation or up-titration of ACE inhibitors or ARBs. And the work group debated these at length, and we remain firmly of the opinion that it's just indefensible to titrate blood pressure according to casual, unstandardized office blood pressure measurements, and that the change of practice is necessary in order to improve outcomes for this highly susceptible group of patients. For more information and for a webinar presented by Alfred Chung, you can go to the KDIGO website, and this webinar was recorded some time ago for the ISN, and you'll get a slightly different presentation of largely the same recommendations from Alfred as you just have from me. Thank you very much indeed for your attention. In case you're interested, this is a picture that I took on a bike ride a week ago through the moors of southern Northumberland. And what you see is an abandoned lead mine, miles and miles and miles from the nearest town. Thank you for your time.
Her üç konuşmacımıza da teşekkür ediyorum.
I would like to thank to all three speakers. I think we can start asking the questions, and I'm going to ask you to give very short answers if possible. The first question goes to Dr. Wong. We have three questions to you. The first one is posed by Mr. Hacietar. So, in invasive operations, if we cannot get an extra benefit post-transplant if with invasive, would it be useful to reduce the solvent trifluency?
I just want to repeat the question, is that would revascularization reduce the risk of death after transplantation? Was that the question?
Hayır, azaltmıyorsa, if the
No,
invasive
it the
can we consider decreasing left ventricular hypertrophy in
left ventricular hypertrophy? Yes, look, I think, again, that is an excellent question. I can only report data in a non-transplant population. The primary outcomes of the key trials actually didn't assess the actual left ventricular size post-revascularization. But one would expect there may be some benefit, particularly in patients with significant vascular stenosis. But I cannot answer those in a specific transplant population because there are actually no evidence to support that.
Diğer soru ise
the next question is to Dr. Is coming from Dr. Kevin. In type 1 diabetes patients, or instead of only transplant, can we do simultaneous pancreas and kidney transplantation? What is your recommendation about simultaneous kidney and pancreas transplant at the same time? And I think in the guidelines, is there any recommendation about it?
Yeah,
Yes.
so I like to emphasize the current KDIGO guidelines focus solely on kidney transplantation, not multi-organ transplantation. However, we are a center that does simultaneous kidney pancreas transplant in Australia, and that will be the treatment of choice for patients with type 1 diabetes, much younger age. We do have an age limit of less than 50 years old, specifically to our center and within Australia, without significant vascular disease. We know that by transplanting these patients early, we have substantially reduced the vascular risk after transplantation compared to being on dialysis, as well as the microvascular complications and autonomic neuropathy. So yes, SPK transplantation is definitely the treatment of choice.
Bir diğer son sorumuz
Last question to Ms. Wong is this. It's about a case, specific case. In preoperative myocard infarctus is high, and there is a common atherosclerotic vein disease. Coronary artery bypass graft surgery was not made. So can you put this patient in a kidney transplant list, or would you do a transplant if this person has a live donor who wants to give a kidney? What would be your preference in
Oh,
person?
this is solely my personal opinions of what I have seen in the times of practice that we had. And I personally am totally, this is evidence-free zone, would be very cautious of putting someone of extensive vascular risk, particularly people who had a prior history of coronary artery disease with significant reduction in the left ventricular function on the transplant waiting list. Because we know the perioperative risk is extremely high of any cardiovascular event. Once if they've actually gone through that very early perioperative phase and they survive that period, the expected survival is actually generally similar to people without significant vascular disease. But it is that very early period that I'm very concerned about. So from my perspective and how my practice run, I would be very cautious.
Teşekkür ederim Sayın Mustafa Arici Hocam.
Doktor,
Thank you. Now, we have a lot of questions to Dr. Nikhil Tandon. I'm going to put them in groups, and I will. Now, he's naming the list of the doctors, Turkish doctors who posed. The question is this: why metformin plus SGL2 be recommended together? Can we not start SGL2 only on its own? According to a recent meta-analysis, says that SGL2A inhibitors are effective on their own. What is your opinion about it?
Thank you. I think the primary
Teşekkür
reason is
ediyorum.
that
Bence
metformin has
bunun
been around a really
Teş-
long time. We have exceptional quality of evidence about it, how it works. It's been shown to have multiple benefits, both glycemic and in terms of cardiovascular outcomes. So there was, at the moment, there didn't appear to be enough information to dislodge it from its position of preference for people with diabetes. There is no question that SGLT2 inhibitors, as a relatively newer kid on the block, seem to be coming up with some great advantages, but it was felt that we retain metformin as it is, and then as a next agent of choice, we bring in SGLT2 inhibitors. Also remembering that because of the recent evidence on cardiovascular benefits and on renal outcomes. But metformin, I think, because of its really long-standing body of evidence, still remained as the drug of choice. Having said that, there are issues with tolerability of higher doses of metformin, and if those are encountered, clearly bringing in SGLT2 inhibitors earlier in the treatment flow would be very much valid and welcome.
Yine Doktor Tandon'a bir soru.
Another question to Dr. Tandon. In phase 5 dialysis chronic kidney patients, basal insulin usage, what is your opinion about that? In GLP receptor agonists, when a person is independent on dialysis, would there be a higher risk of further disease?
So really, there are no good data for GLP-1 receptor agonists once the eGFR drops below 15, and for that matter, on people on dialysis. So this would again be an individual choice of the practicing nephrologist, endocrinologist, and it would not make its way into the guidelines. Basal insulin, I mean, so once you hit the level we're talking about, and you can still try agents like linagliptin because these work irrespective of the estimated GFR. But if they are not efficacious, then basal insulins plus small bolus doses, depending on the meals, would be our preferred choice, because that's standard practice, and that yet hasn't been replaced by any other agent because of the absence of clear evidence from about those agents.
Teşekkürler. Çok az zamanımız kaldı ama
Thank you. We are running out of time, but we have two questions to Mr. Tomson. Dr. Yasemin is asking to you. In chronic kidney disease, strict blood pressure control would require a lot of diuretic usage, which would cause increased hyperuricemia kidney disease. So would you recommend routine uric acid decreasing treatment?
Thank you for the question. There's no good evidence that uric acid lowering treatment is of benefit either in preventing the progression of kidney disease or of its complications, although there was a very recent CJASN paper that I think came out yesterday that hints at some benefit. Certainly it's beyond the remit of the guideline, but the guideline doesn't make specific recommendations for the use of urate lowering treatments. My opinion is that if somebody develops symptomatic gout, they should definitely be treated. But in the absence of symptomatic gout, one has to balance the theoretical benefits of urate lowering with the additional pill burden that would be entailed.
Teşekkürler. Charlie, bir diğer soru Gülay Koçak.
Thank you. Next question to you is coming from Dr. Gülay. In the blood pressure, monitoring with office blood pressure, would it cause hypotensive episode frequency to go up in patients who are afraid of white shirts?
It's quite possible that reliance on office blood pressure measurements in those patients with severe white coat hypertension will lead to over-treatment. And that is why we do recommend the adjunctive use of home or ambulatory blood pressure measurements. And if such measurements do show a tendency to white coat hypertension, then the treatment should be tailored accordingly. And one shouldn't just rely on the office blood pressure measurements in that situation.
All right.
Kan basıncı, Charlie bir soru daha var.
Charlie, one more question. In the monitoring of blood pressure, which methodology should we use more often? Standard measurement, home measurement, or telemonitorization?
Well, for the adjustment of antihypertensive treatment, the KDIGO guideline clearly suggests that standardized office blood pressure is the right approach. My personal practice is to have relied more on home blood pressure measurements, and the COVID-19 epidemic has, at least in this country, allowed us to be much more reliant on home measurements because we're trying to avoid bringing people to clinic. And in far-flung places where home measurements are cheap, there is the additional benefit that patients feel more in control and feel more activated and involved in their own treatment if they're monitoring their blood pressure at home. So I think there is a definite role for home blood pressure monitoring, but if one relies on the trials, and the KDIGO is very clear that we should rely on the evidence, then the evidence is that we should adjust our treatment according to standardized blood pressure measurements. In practice, it's going to be a combination of both, and it will be a combination that will vary depending on the geography and the resources of the country that's implementing the guideline.
Süremizi aştık. Birkaç soru.
We have passed our time. We had many more questions, but we did complete our time. So I'm very thankful to all of the three speakers. Together with Mehmet, we hope to host you in Turkey in person, and maybe we can organize a KDIGO session here in Turkey. So I'm sending greetings to Newcastle, Sydney, and Delhi. I wish you health and healthy days, and I'm sending my respect to all colleagues who have been listening to us.
Thank you.
Thank you.
Thank you so much.
Thank you.
It's been a pleasure.
Thank you very much.
Bye-bye.
Thank you.
Take care.
Thank you. Thank you. Bye-bye.